Good morning, and welcome to the 19th National Forum Annual Meeting. While I wish that we could be together today in the same building, I'm pleased that we can gather virtually, and I'm delighted that we are setting a record for the largest National Forum meeting ever. Thank you. I want to begin by pointing out a few things about the virtual meeting. First, while we may be physically separated, we can still be part of the conversation throughout the day. Please use the chat function to comment on the meeting topic and panel discussions, share information, and catch up with friends and colleagues. We are using closed captioning. You can control how it appears on your screen by using the CC button on Zoom. To ask questions, please use the Q&A feature. The panels may not get to every question today, but we will gather all of the questions and see if we can include responses with the meeting summary. That reminds me, this meeting is being recorded. If you have colleagues who cannot be with us right now, they will be able to catch the whole meeting on demand in a couple of weeks. When the recording and meeting summary are posted, the National Forum will send you the link. Please share it with others who may be interested. Biographical sketches for all of today's speakers are in the virtual program book. They are impressive, and I commend them to you. This convening and your no-charge participation are made possible by our generous sponsors. Thanks to Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Esperion, Merck, and Novartis. Our friend Jill Birnbaum at the American Heart Association says the National Forum Annual Meeting is the one meeting of the year that brings together all of us who are working to prevent heart disease and stroke. Thank you to the sponsors for enabling us to come together. Following our panel discussions, National Forum members will have the opportunity to share the actions they're taking to carry out the charge from any of the three panels. It will be kind of like speed dating. Each member will have a maximum of 2 minutes to tell us about the actions they are taking. So, as you listen to the discussions today, think about the actions that your organization is taking or could take to help the U.S. reach cardiovascular health equity. Throughout this convening, you will get glimpses of Trent Wakenight's visual works as he creates a graphic record of the meeting. Later in the meeting, Trent will provide a quick recap of key points that will pave the way for members' action updates. With this meeting falling during the World Series, it seems fitting to note that since we met virtually 1 year ago, COVID-19 has thrown a lot of curveballs at us. The pandemic has taken the lives of more than 700,000 souls in the U.S., more than twice the number of Americans who lost their lives in World War II. COVID-19 has been indiscriminate, affecting all ages, races, and places. At the same time, it has discriminated, with its greatest burden hitting certain ages, races, and ethnicities. As if that was not bad enough, the fallout from COVID includes a worsening of another pandemic, the one that remains the leading cause of death in the U.S., cardiovascular disease. If there are any upsides to the COVID-19 pandemic, they might be that, first, more people are aware of health inequities, and second, people have greater appreciation for public health. While we hear and understand a wish to return to normal, I believe I speak for all of us who are here today that we want to help our country reach a new normal or a new paradigm in which the U.S. invests where it matters to eliminate health disparities, to slash intolerably high maternal and child mortality rates, to exceed 80% hypertension control across the population, and to equitably improve cardiovascular health. We do not just understand the desire to work, play, pray, and shop without fear of a deadly virus. We share that desire and more. We, the members of the National Forum, seek not the past, but a healthier future for all. To that end, the Board of Directors approved a new strategic plan for the National Forum this year. It lays out strategies, approaches, and goals to lead us toward our vision of people throughout society living heart-healthy, stroke-free lives. It doubles down on our mission to lead and spark collaborative action to achieve health equity and optimize cardiovascular health and well-being throughout the lifespan. We will hear more today about the two pandemics, what a healthier post-pandemic normal or paradigm can look like, and the actions that National Forum members can take and are taking to ensure that we move forward together. We will begin the meeting with the launch of the National Forum's fifth signature report, which we affectionately refer to as the Sidney Report. I'm pleased to introduce the founding executive director of Million Hearts, and now the director of CDC's Division of Heart Disease and Stroke Prevention, Janet Wright. Dr. Wright will have a conversation with Steve Sidney, Director of Research Clinics at Kaiser Permanente and Chief Scientific Advisor to the National Forum, about the new Sidney Report titled Two Pandemics, Collision and Chain Reaction. Dr. Wright?
Steve, the report describes a collision of the COVID-19 and cardiovascular disease pandemics. What's meant by this?
Well, COVID-19 and cardiovascular disease are both worldwide pandemics. COVID-19 has caused nearly 5 million deaths worldwide and over 700,000 in this country, in the United States. Cardiovascular disease caused almost 16 million deaths in 2019 from heart attacks and strokes. And in the United States, that was internationally. In the United States, it was more than 800,000. The collision means that each of these pandemics, as they meet, basically causes the other one to get worse. COVID is associated with increased cardiovascular disease, including heart attacks, acute coronary syndrome, thrombotic events such as ischemic stroke, pulmonary embolism, and deep venous thrombosis, and myocarditis. On the other hand, the cardiovascular risk factors, including diabetes, hypertension, smoking, physical inactivity, and obesity, are associated with increased risk of serious COVID outcomes, including hospitalizations and deaths.
It's staggering, Steve. What we've discovered, what we've learned the hard way is that some populations are more afflicted by both COVID-19 and cardiovascular disease pandemics. What does the report tell us about disparities and health?
Well, disparities among the major race ethnic groups have been reported widely for COVID-19 and include both infection rates, hospitalizations, deaths, and serious illness. And they are much higher in Hispanics and in non-Hispanic Blacks. In fact, the mortality rate from COVID is more than twice as high in Hispanics and non-Hispanic Blacks than in each of the other major race ethnicity groups. Similarly, there are disparities in cardiovascular disease, and notably, for one thing, the rates of mortality from stroke and heart disease are each more than twice as high in these same groups, the Hispanics and non-Hispanic Blacks. But what is really kind of shocking is what happened during COVID. So between 2019 and 2020, the mortality rate from heart disease increased by 4%. It's only one of three increases that have occurred since 1968. And the mortality rate from stroke increased between these 2 years by 7% after being relatively stable over the last several years. But what's going on in non-Hispanic Blacks and Hispanics is truly shocking. The number of deaths from heart disease increased by 16% in Hispanics and 14% in non-Hispanic Blacks from 2019 to 2020, just 1 year, while the number of stroke deaths increased by 12% in Hispanics and 11% in non-Hispanic Blacks during the same time span. These increases are well over double the magnitude of the increases in each of the other major race ethnic groups. They are particularly concerning for the non-Hispanic Blacks because they already start with the highest rates of heart disease and stroke mortality of all the major race ethnic groups. Now, disparities have resulted in differences in preventive care and medical care during the pandemic. So what we have seen is hospitalizations have increased. Hospitalizations have increased due to COVID, and they have, during surges, hospitals are overcrowded and unable to adequately treat the numbers of acute cardiovascular events such as heart attacks and strokes. So that's one thing that is going on. The fear of getting infected keeps people away from medical care facilities when they really need it for acute care. Living conditions may be substandard and overcrowded, and people may live in food deserts in which it is very difficult to get healthy food. Employment exposures are more common in people in lower socioeconomic status. Public transportation, which many people rely on to get to work and to get to medical care, is a source of exposure to COVID. And it may be difficult to get regular physical activity because the area you live is unsafe, or because there's a lack of parks or other open spaces for safe physical activity. Finally, vaccination rates are lower in Hispanics and non-Hispanic Blacks because of all of these factors, because of misinformation about the vaccines, and because of a disparity, inequity created by the age guideline for vaccines, which I'll tell you about in a moment.
Yes, Steve, you outline the perfect storm, or this collision dynamic that you've described so well in the report. You know, older individuals, due to their higher risk for severe COVID-19, were deemed initially a priority population for vaccinations. There were some unintended consequences of that recommendation. What are those? And what are the solutions?
I want to start by saying it's got to be extremely challenging to develop guidelines for vaccination, and both scientifically and politically. What happened here is that using this age cutoff basically provides vaccine protection to a much greater proportion of white persons than people who are Hispanics or non-Hispanic Blacks. Specifically, 85% of all COVID deaths occur in whites who are over the age of 65. So they would get protection from the vaccine, presumably, since it usually protects from death. The proportions who are of people who die from COVID who are non-Hispanic Blacks and who are Hispanics is much lower, between 60 and 70%. Stated another way, vaccinating using this guideline would leave unprotected just 15% of whites under the age of 65, but more than double that percentage of non-Hispanic Blacks and Hispanics. Given the, one thing we could do would be reduce the vaccination age recommendation to 55 in these groups, which would nearly eliminate less disparities. But the other thing that we actually think is that all non-Hispanic Blacks and Hispanics should be vaccinated because of all the other things that I've outlined that make it difficult for them to get vaccinated. The National Forum is actually going to utilize mayors and the military to promote this message to vaccinate all people.
Steve, the report proposes a new message that cardiovascular disease prevention is COVID-19 prevention, and COVID-19 prevention is cardiovascular disease prevention. How should our partners use this message?
Well, our partners, I think, are already advocates for cardiovascular disease prevention in more traditional ways, such as, for example, hypertension control. I think we need to add COVID-19 vaccination to the message of cardiovascular disease prevention because of all of the reasons I have described earlier. This means that we should advocate for all people who are eligible to get a COVID vaccination. Moreover, we need to support public health, and we need to support the leaders and professionals in public health, particularly in this time where there is a significant number of people, though not a majority, who seem to be anti-science and anti-public health, including, unfortunately, some of our political leaders. So we need to provide support to public health so it can do its work and that its recommendations for COVID mitigation are taken seriously, including vaccination and where and when appropriate, social distancing and masking. Conversely, we need to continue our communication and advocacy for the control of cardiovascular risk factors in order to do our main mission to reduce and eliminate heart disease and stroke.
Well, and we'll close, I think, with one more question, and that is that the report recommends increasing physical activity as a way to reduce the risk of COVID-19. What's the connection there?
Well, physical activity levels at the population level decreased during the COVID pandemic substantially, both in this country and internationally. As we know, physical activity puts one at risk for weight gain, obesity, and depression. But what was recently shown in a study in Kaiser Permanente in Southern California was that people who were persistently physically inactive had more than twice the risk of serious COVID outcomes, including hospitalizations and death, than people who consistently met physical activity guidelines. And they were also at increased risk over those who just were physically active sometimes. This has led us to coin the phrase, walk away from COVID. And if you utilize this, walk away from COVID by walking briskly 150 minutes a week for 30 minutes, 5 days a week, you'll meet physical activity guidelines and reduce your risk of serious COVID complications.
Steve, thank you. Thank you for all of these thoughtful answers and for the report, not just this year's report, but the reports in years past. All of the National Forum members can implement the recommendations from these reports, and we look forward to getting healthier through your guidance. Thanks so much. Back to you, John.
And thank you, Janet.